Welcome to everyone to our first event in our new faculty series, Insights to Action. My name is Sarah Ayler, and I'm the Director of Alumni Relations and Annual Giving at the Carlson School of Management. We are delighted to bring this new virtual series to you, featuring thought leadership and key insights of our faculty. The goal of this series is to translate business research into practical knowledge for business leaders. This series is a partnership between Carlson School's Office of Alumni Relations and Annual Giving and our Executive Education Office. We are excited to welcome over 300 alumni and friends in attendance today. To kick off the series, our event today will cover a topic that impacts all of us, supply chain leadership in COVID-19 times and beyond. We are joined today by two Carlson School faculty members, Steve Parente and KK Sinha. Steve and KK will discuss how the principles of supply chain leadership contribute towards addressing many of the challenges faced during COVID-19, while also examining the U.S. government's efforts to engage with private and public healthcare sectors to help us address some of these challenges. It is my pleasure to introduce our panelists today. Our first panelist is Steve Parente. He is a professor in the Department of Finance, the Minnesota Insurance Industry Chair of Health Finance, and Associate Dean of the Carlson Global Institute. Many of you may know Steve from when he served as Associate Dean of MBA and MS programs. He's also the former director of the Carlson's Medical Industry Leadership Institute. Professor Parente specializes in health economics, information technology, and health insurance, and has been the principal investigator on large funded studies regarding consumer-directed health plans, health information technology, and health policy microsimulation. From 2019 to 2021, he served as chief economist on the Council of Economic Advisors for the White House. Before Steve kicks us off, one bit of housekeeping. Following the presentations, there will be time for Q&A, so please feel free to put your questions in the Q&A function of Zoom. We will try and get to as many questions as possible. Please join me in welcoming Professor Steve Parente.
Thank you, Sarah. Great to see you all. Let me go and share some of my slides to kick us off here. So I'm very excited to participate in this. Just the title of the notion of this, of insight to action. This is COVID-19 brought a lot of action into my life in unexpected ways. So let me just kick off with just a little bit of a timeline here. So as Sarah said, I served in the White House starting actually in 2019, but then was about to leave in 2020 when COVID started to kick in. We were tracking it fairly early on. Actually, I'll show you in a second, we were thinking about pandemics even before that. And by about when things really got bad in March, my role changed over to become a senior advisor to HHS Secretary Alex Azar, and then came in to be chief economist to drive a lot of the stuff going into Operation Warp Speed. So I'm going to talk about what was Operation Warp Speed besides a homage to Star Trek. Actually, probably one of the most successful things I think the federal government has really ever engaged in a situation like this. Granted, there wasn't really not much of a playbook for it, for the U.S. to do this, and then show you some basically insight to action from my own research and just what I've worked with in industry before, from first the carnage of the pandemic and then hope going forward. So one thing to keep in mind is that the Council of Economic Advisors, which is designed to be a neutral advisory group to the President of the United States. Every President of the United States has had one of these since 1946 when it was legislated. We actually wrote a report in September of 2019, basically saying what would happen or what do we have to worry about in case there was a pandemic, and how can we get vaccine innovation going, given that vaccines are typically pretty hard to produce, and in some cases are thought of as a market failure. Technically, they're not that hard to produce. They're just underfinanced in terms of getting them to go. So one thing that unfortunately we were pressing about this, we actually said in this that we find it if it did occur, you could have the economic damage to be anywhere between 413 billion to 3.79 trillion. And that basically fatalities in such a scenario could be at least 500,000 people in the United States, with many people being hospitalized up to millions. And also that basically this will incapacitate a large portion of the population and critical infrastructure that needs to be dealt with. September 2019, this is before the Wuhan virus takes on. So Operation Warp Speed basically was motivated by that document because we made an economic argument as to why one would have to actually really open up a lot of money given what the consequences were. And I'll show you exactly what we still put together for that. Part of it was figuring out that there needed to be a public-private partnership. And in terms of the public sector actors, the Department of Health and Human Services, and then under them, the Center for Disease Control, NIH, and BARDA, think of it as sort of a biomedical version of the defense industry's DARPA to basically put, and then in specific efforts, the idea was that we wanted to work with industry, basically get to rapid interventions as soon as they were developed and actually put them into production, understanding that the clinical trials would take potentially months to be done. And originally the clinical trials are forecast to be taking years, but the thought was if we could shorten that and use emergency use authorization, we might be able to move faster. So the what of Operation Warp Speed was to essentially have a deployment of the promising vaccines earlier than development, basically to make them while we were testing them. But at the same time, adhering to standard safety and efficacy protocols. We were fortunate that we actually knew something about the virus before it actually occurred, and in terms of what the structure was, and that an mRNA solution was possible, mostly because mRNA solutions were already talked about for other things such as Ebola. So the timeline was to get this out, and the thought was if we didn't do this, we wouldn't see a vaccine until September 2021. And if we could get it out as early as January of 2021, we could save essentially $2.4 trillion, or about $155 billion per month. Here's the rationale that we use for that. This is actually in our economic report to the president that came out this past January. This actually shows on the left what the economic cost was. The reason why there's jagged lines, we were measuring and tracking all this. I'll show you this in a second. And then basically the thought is we can get this to be available in January versus September. We can basically try to short circuit some of the costs that would be associated with this. We did forecast that there would be, unfortunately, this second wave bump as well. So this is the savings that we could try to achieve if we can accelerate to get the vaccine available by that point in time. And the idea being that if we can get development in play, the thought is with $3.8 trillion, if we can get the full value of the vaccine up on January 1, if we do it by September, it's 1.4 trillion, and the 8th month benefit. Now, I mean, there's lots of ways to calculate this, and economists wave their hands all the time, but the point was, this is what motivated the White House at that time to push very hard, working with Congress to put out as much money as possible to drive these vaccines forward. And fortunately, it actually happened. We did have by mid-December, both in the US and UK, basically not just one, but 2 vaccines available. So that was one step of the process, and that's all sort of internal. What then happened was suddenly I got more or less tasked for lack of a better term, operational duty. It sort of brought back when I used to work for the insurance industry way back when I had hair, back in the 80s and 90s, to kind of do really kind of executive function pieces. So at one point I was called into a meeting when I thought that I would be leaving the White House in April last year, kind of doing my tour and come back and be at Carlson. And then basically walking in there saying, you know, you want me to figure out how to spend what? $175 billion, because basically the entire health economy had shut down in mid-March, along with the rest of the entire economy. And the problem was that, you know, normally, you're going to need that healthcare economy to actually treat people. And many of the hospitals had no more than 8 or 9 days cash on hand. Plus, we wanted to set up a program for the uninsured to get COVID testing and treatment at the same time. So in terms of the, if you will, flipping back to basically insights to action, one thing that I was involved in the year before was to get a price transparency executive order out the door. And the idea was to get consumers to see better information on prices. But part of that, and actually I wrote a good bit of this executive order for the president to sign, was to create a synthetic database that would basically give us access to all payers of the health insurance industry that would be eventually put out for free. Now, this is actually going to be available in another month or so, but I had an early stage version of it as a prototype because I made one from when I was basically as a professor and put this actually from a Canvas screenshot. I made one from other databases that I had available from research I've done looking at the commercial insurance sector for the last 10 or 12 years. And from that, was able to actually inform the Secretary, the Chief of Staff of the President, what it would take if we were to operate under these principles of fast, simple, fair, and transparent to get basically as much money out to these providers as we could, and using mostly some of the information we already had available on the Medicare and commercial sectors to get it out. And our thought was, if we know 1 month loss is 140 billion. If we can get 50 billion out, that'll at least cover some of their expenses that they're losing from basically losing all their elective surgical procedures, which is the bread and butter of most major hospitals in the US today. So we put this into action. Basically, this was the blue sky. This is really directly from the presentation that we actually gave to the Chief of Staff, saying $50 billion is in tranche one. We're going to put $30 billion out that will be overnighted through banks, through the US Treasury, and then $20 billion we need to have be defined basically by people putting in their expense reports. But the thought is we would at least get hospitals to be covered for the lion's share of the money that they were losing immediately. So this actually was a 2-week process, so that basically this slide was created on March 30th. And then on April 11th, we overnighted $30 billion to 300,000 Medicare providers across the US. No one had ever tried this before. And actually, we were getting calls the next day. For hospitals, like for example, the Mayo Clinic got overnight $60 million in their bank account. And they were like, is this a fraud thing? What happened? It's like, no, we're trying to help. Here's the background. Here's the FAQ. You can read what we're doing. And this actually continued on and through July till we got $100 billion out the door. And then the other question was, what about Medicare? Well, what about covering the uninsured? And so in this instance, we also were engaged, figured that probably about 10 billion of the 175 billion should be set aside for this population. But essentially, we had to stand up an entire Medicare for all style health insurance company for the uninsured. And this is actually what we did. We actually paid out to date about $2 billion, both for treatment and for care of the uninsured. Normally, a program like that would be done for a hurricane, and it's usually regional to say, in Florida or Texas or some other place where the hurricane would be afflicted. There would be a stand-up health insurance function that's there for people that don't have heavy insurance coverage. Since this was a national emergency, we actually expanded the entire scope to the US and proved that you could literally stand up a single payer system for the uninsured. In our case, in 3 weeks, working with the private insurance industry. Interestingly, the states that actually got the most money were the largest ones, but also, if you know how some health policy works, the states that also did not expand Medicaid, that is the program for the poor, namely Texas and Florida, got a disproportionate share, and a lot of the southern states as well. Darker red means more money, basically to compensate for not have safety net systems available for their populations, just in the general anyway. And on top of that, we actually started to develop fast tracking systems because we needed to have some eyes on how things were progressing. We use the Medicare data system, which basically is the closest the US has to a single payer system, but just for seniors, to track actually how the system really just exploded in terms of COVID hospitalizations and where things were tracking well in advance of what all the COVID tracking projects are doing. And actually then work with the commercial insurance sector to see what we can find out in terms of telemedicine and telehealth. So a blog that I wrote in the White House, we actually were able to track using claims data from the commercial insurance sector, how telehealth went from nothing basically to being close to 30% of all services rendered because people just couldn't get out anymore. You can see the drop off in hospital outpatient that occurred along at that same time. At least that told us people were getting access and where they were going in terms of their areas. The other thing the data could do was actually show us how transformative telemedicine might be as a technology. So this is actually from the data system that was provided to us for free by the private sector when we asked them. This is looking in January, basically February 1st of 2020 compared to January 2020. All these things are where little telemedicine sites are operating. But watch as we go forward into March, which is right before the shutdown, and then into March and April. Basically, telemedicine just explodes, essentially as a way to treat upper respiratory conditions, and actually then stays as we go into November to be a major way of folks to be treated while they're still locked down. On the other hand, this shows the alternative way of using physician services. Again, February 1, more red is more service use, green is less service use. So basically, you're actually watching COVID happen right now. We were tracking it earlier than people might expect. And then suddenly we get to the shutdown, or right before the shutdown piece on March 7th. When we're into the shutdown, notice basically the entire physician service sector is shut down. No one is being tested for COVID that way compared to, or any upper respiratory or flu, but it does slowly come back. And actually, sadly, we find that when we get to December, we actually are able to track essentially how the second waves or Thanksgiving started to progress. So these are great tools that we did not have access to before because of essentially cooperation with the private sector to really sadly measure the carnage of this. I always feel bad when myself or Pinar looks at this type of information because you're really looking at people dying. It's not something to be celebrating. But the things that we can celebrate is the vaccine, where Operation Warp Speed really yielded. So this is the last blog that I managed to put out while in the White House, basically tracking state by state how these vaccines were going out the door. And initially, not much at all, but strangely, Alaska, West Virginia actually led the way. There's some really good stories as to why West Virginia was able to do that. And to today, now we have, and I sort of track these things daily from the CDC information that's available. States in green are doing much better. So Alaska is at 26%, West Virginia is at 22%. Minnesota is doing better, but there are other states in the South that are catching up. Now you might say, why couldn't we do this in a better distributed way? I'm sure KK will talk about this as well. Basically, notice my hashtag federalism to normal. For better or for worse, a national emergency is a defense operation like a war, but a national public health emergency actually falls into public safety, just like law enforcement. And so we don't have laws to basically let essentially a national response occur yet. That has to be voted on Congress. So key takeaways in terms of this whole odyssey and arc of going essentially from insights to action. Trusted connections matter. All of the data and pieces that went into play were essentially connections built over a period of time. Execution counts in terms of days and hours. These folks are here are basically the folks that were there on my boat, basically programming out, we were having to move $30 billion. We look happy only because the money just moved by instruction set an hour before. And then these are the folks, myself and two other senior advisors that really spent countless hours basically living in Washington together under COVID restrictions for about 3 solid months, just making sure the money kept moving and that we had good tracking on what can happen. But the nice thing is, even when we had opposing personalities, we found that business could be a force for good and we can try to make some really great stuff happen. That I really enjoy welcoming KK to talk about how we can make the supply chain better, because no one expected how to do this, but at least we tried to do the best we could. Thank you.
Thanks, Steve. And now it is my pleasure to introduce KK Sinha. KK is a professor and chair of the Supply Chain and Operations Department and is holder of the Elmer L. Anderson Chair in Sustainable Supply Chain. He also serves as a graduate faculty in bioinformatics and computational biology. His research interests include technology and innovation management, healthcare supply chain management, global supply chain management, and big data analytics. His recent projects include studies on designing and sustaining physical and mental healthcare supply chains and reducing the disparities in healthcare delivery during COVID-19. Please join me in welcoming KK Sinha.
Good morning, everybody. Welcome to our event, Insights to Action. I wish I could see you in person, but I really thank Sarah and Nora, Amy for organizing this. And this is one way for us to connect on issues of importance. And I'm truly grateful for the opportunity to be here with Steve, from whom you heard firsthand his experiences sitting in Washington, D.C. and tackling this COVID-19. My approach would be a little bit more boots on the ground approach, and also that of an academic. So I'm not beholden to anything other than the fact that how can we make sure COVID care available as soon as possible and get what I would call life and livelihood back on track. Let me begin, because many of you are alums, so I also extend my greetings to you on behalf of our group, our Supply Chain Operations Management Department. I put this up because many of you would recognize our faculty and have interacted with them in the past. But what I would like to also suggest and mention to you that we truly are a group driven to developing supply chain leaders. That what keeps us going. Let me begin by saying that, anytime we talk about this, it's worthy of taking a moment to acknowledge what we have faced and are facing. It is the worst of times, no matter how we want to think about it. And let's acknowledge those who are no longer with us, no longer have a seat on the table. We owe it to them that we tackle this issue head on. These were lives that were unnecessarily wasted. And so we need to pay our tribute and respects to them, and truly our thoughts and prayers with their families. But that should also inspire us and more determined to plow ahead. And the real inspirations are from the people. When the worst brings out the best in people who have been putting up in ungodly hours, have been on the line of duty and facing and taking care, so that they are taking care of others, doing the best they can. And this is truly across the whole globe. So we can't thank them enough for what they do and are continuing to do, because that's effectively the bridge to a better tomorrow. But they're also a source of our inspiration. And so, if you think for a moment, then here is how I would like to characterize. The COVID-19 times have been a traumatic experience, truly a crisis of unparalleled proportion. No matter what we say, it's also a humbling experience, notwithstanding that we are an advanced industrialized nation. We are on our knees so far as COVID-19 response is concerned, and we're trying to get up and tackle this issue. Most importantly, I think it's a learning experience. It's a shared learning experience. And in the spirit of a leadership mantra, crisis is too precious to waste. This is an opportunity for leadership, supply chain leadership development and demonstration. And that's effectively the theme that I'm embarking on. So what are some of the key learnings during COVID-19 times? A lot of these relate to our products, be it PPE, test kits, ventilators, and now vaccines. There are processes of not only having the test, but also testing, having vaccine and vaccination, where we are still figuring our way out of it. There are issues of inventory, the stockpiles. We learned that we had stockpiles of inventory, but a lot of them were not maintained, and they could never be places that they needed to be. And then there's the whole issue of capacity, hospitals and intensive care units, and I think a lot of it, I think Steve's presentation captured very well graphically. And finally, there's the workforce issues. I mean, those who deliver care and do the essential work. And we figured out and are figuring out what is truly the essential work. And from that standpoint, we also need to begin to recognize that COVID-19 has given us a window into quality of our goods and services. How do you sustain it? We have looked at both the good, bad, and the ugly. All in all, these are what in operations parlance, what we call the process inventory capacity, workforce, and quality decisions, which are the building blocks of supply chain leadership. And so when we start thinking in terms of the relevance and significance of supply chain, I would venture to say that if there is one thing that COVID-19 has made happen is to make us realize this relevance and significance. We started seeing the word being used in media, and I think it has gotten in the vocabulary of folks. Most importantly, even more recently, we realize that Steve talked about Operation Warp Speed. But the reality is that just half side of the story, which is all about development of care, we still don't have, and we are still figuring out what we call as the delivery of care, which is Even most recently, President Biden talked about this is a gigantic logistical challenge. There are other bits that is worthy of pointing out in our own state. Sometimes we don't like to talk about it, but it is a reality that effect of COVID-19 has been unequal. It has impacted certain subpopulations, racial, ethnic minorities in ways that is far more severe than the others. And so we need to be mindful of that reality. And it's COVID-19, if it has done one thing, it has only exacerbated the disparities that tend to exist in our healthcare system already. And I mention this is because I think as an aside, I would like to mention that when we look at, say, the COVID-19 task forces, to date, I don't think there's a supply chain expertise on that team. People have other backgrounds, but there are epidemiologists, there are public health professionals, there are economists, there are medical professionals, but there isn't what I would call a straight up supply chain or healthcare supply chain guy sitting there. One thing that McKinsey points out, and I think this is gathering a lot of traction, is when we think in terms of post-crisis tomorrow, what is needed? And what is needed is supply chain leadership. It's one of the 5 capabilities that is deemed that matter most. So let me give you a flavor for what that means right here on our campus, in our school, and how this is being manifesting itself in our school, in our enrollments. I think there is something to be said here because, again, when we start thinking on the ground, then we are beginning to see that we are ourselves becoming more enthused, more excited, and are willing to roll up our sleeves and start understanding the nuts and bolts of supply chain that would make us a leader. So this program that we created, and this has been about 5 years in existence, is geared towards developing supply chain leaders. And it gets into the principles when you start thinking about it, about what is that constitute a supply chain leader. This is a program that looks at things like strategic orientation for sure, global perspective, social responsibility, and analytics. And this is something that is being rolled out. It attracts the best and brightest from our Twin Cities companies. They're sponsoring them. And it's very heartwarming to see that another group, which is a hunting ground for leaders, the veterans, are finding this program as a way to transition to civilian careers. So what does a supply chain leader is able to do? What are some of the capabilities? So one of the things is a supply chain leader can conceptualize and operationalize supply chains end-to-end, connecting the sources of supply to the sources of demand, cutting across firm boundaries, country boundaries, and even reaching to what we would call the underdeveloped countries, or what we would call the bottom of the pyramid, regardless of where we are. We are also about designing and executing win-win-win proposition. We share the risk, we share the rewards. One of the things that COVID-19 helps to highlight is how even states fought with states to get their share of not only vaccine now, but ventilators not that long ago, rather than we need what we call win-win-win proposition. And I think that is what supply chain leader brings to the table. And finally, a supply chain leader is able to truly straddle between the forest industries, strategize and execute, walk the talk. And what I mean here is when you think about Operation Warp Speed, that's a wonderful story of development of vaccine for COVID care. What we never got is how do we deliver it? And not just fulfillment, the last mile is the last inch, which is the syringe in one's arms. For a supply chain leader, what's the North Star? It's designing and sustaining supply chains that are reliable, i.e. producing, delivering high quality goods and services safely. It's being responsive, being right product at the right place at the right time, and responding quickly to the unexpected events. And resilience, more than ever before, has hit us, which is how can we design a supply chain that is robust to risks and disruptions, both man-made and natural disaster, which is a non-trivial issue not only we are living through, but anytime we globalize our supply chain, that is effectively a reality that we have to face up to. And finally, being socially and environmentally responsible, that nobody is being left behind as we are vaccinating our citizens. So let me give you a simple illustrative study to illustrate, what we have been doing, and then that begins to help inform what we are teaching. So one simple way to think about it, think about a COVID care supply chain end to end. Think about it in the Twin Cities. We live in a community. We have learned that we need to keep social distancing, stay at home. Not too long ago, we were told that, there is a COVID-19 checklist, that we should be mindful of. So if we think of, we are having a fever, cough, and shortness of breath, we go out and seek that test. And as we all know, testing was never easy. And even when we got tested, we never got the results back. So there is both a testing capacity, is a process issue, lead time issue. So yes, we get now tested, and then I'm distinguishing between average citizens and healthcare workers, because we know a lot of healthcare workers were also affected, and then some even died, and therefore it's in the proverbial people, process, and technology. If people are not there, we don't have the capacity. So now we have access. So you get the access, you identify people. If they are negative, you go back. If you are positive, or then I think there is some work to be done. Then you basically say those who came in contact, you go quarantine. That's an access issue. Then you get mild, medium, and serious, and then effectively you then land up in a hospital. And these are things that we have vividly seen pictures of, and where we're seeing there are beds and there are ICUs. And then we also do what we call contact tracing, which is going back. And so this is a whole mechanism that has to be working seamlessly 24/7. Now, obviously, if things don't go right in ICU, then the consequence is death. And then hopefully, as things get better, you go back to the community. One thing that we have learned as a supply chain folk, and this is a very basic, that a chain is only as strong as its weakest link. It's a reality that hopefully we can grapple and take to heart as soon as possible. And the weakest link in the COVID care supply chain, from that standpoint, is the ICU, because the consequence of ICU capacity shortfall is death. So a study that we have completed is to begin to understand what are the sources of COVID-19 mortality, and what is the role of critical care capacity, and how it can inform policies to that effect. So we acknowledge that this is a decision that is made at the county level, and we acknowledge that the reality that not two counties, similar population, have very different demographics by age, socioeconomic factors, race, ethnicity, clinical factors, and then critical care capacity issues. So which is ICU bed and frontline providers. So the question that we have looked into is, how does critical care capacity moderate this relationship between socioeconomic, demographic, and clinical factors and COVID-19 mortality at the county level, because that's the locus of decisions. So the policy implications, i.e. so what, who cares, is this is a kind of study that helps, informs, and provides what I would call evidence-based preparedness for COVID-19 or pandemic as such, or any kind of potential disruptions, by prioritizing critical care resources. It allows us to quantify the effect. So the things like, okay, if you increase an ICU capacity by say 10%, what is the implication going to be on the mortality rate or the reduction in mortality rate by all these subpopulations? And that is a question we can now answer. And that in turn can be used as a practical guide to county and state level administrators, and even deciding investments in ICU bed for preparedness like COVID-19. Another study that I just want to briefly mention, because I think there are some takeaways from these studies that when we look at public healthcare supply chain in underdeveloped countries, I think there are some takeaways that can help inform us. So we completed a study on what we call a pull versus push healthcare supply chain in 6 in underdeveloped countries. And I think there are some takeaways for managing COVID-19 supply chain. So one of the simple things that probably a picture is worth some few thousand words, is this is a typical picture that I think we too often see. And this exemplifies what we call pulling people for vaccination. Yet, when we look at the underdeveloped countries, what we do see are these pictures, which is pushing vaccination to people so that no child, no citizen is left behind. And if you look at a lot of the vaccination, including polio vaccination, admittedly, they are not one and the same. There are two modalities of pulling and pushing vaccination. And we really need both. If we want to reach out to the people so there's nobody is left behind, then we better be mindful that just pulling people for vaccination will leave a lot of people out. The second thing about pushing vaccination, we know there are pockets, even with our citizens, and who do not still believe in vaccine. And that is the same thing in other parts of the world. But the most important thing is you are not only providing access, but you're also creating awareness. And both access and awareness are fundamental drivers of estimating demand and fulfilling demand. So in summary, I'd like to say that when thinking in terms of post-crisis tomorrow and leadership needs, supply chain is high up there. You know, when we think in terms of supply chain leaderships, then the building blocks are that of product process, inventory capacity, workforce quality decisions that we make and we study every day. A supply chain leader does conceptualize, operationalize end-to-end, design, execute, win-win proposition, and strategizes and executes. A supply chain's North Star is designing and sustaining supply chains that are reliable, responsive, resilient, and responsible. And I say this to also demonstrate that the thinking about supply chain leadership has already been recognized for a while. And if COVID-19 has done, it has further heightened the significance of supply chain and supply chain leadership. And when I said it has been already recognized in the past, if you were to take a pure leadership trajectory approach and pathway to care corner office, World Economic Forum, for example, recognized, the need for supply chain professionals making. We have think about Forbes talking. And so these are different entities, yet acknowledging the role of supply chain leadership and its significance and its need to be on the table, along with every other discipline and relevant to this, handling this pandemic and beyond the pandemic. So that's really my thoughts. Thank you all for your attention and love to take questions. I turn it back to you, Sarah.
Thanks, KK. And thank you, Steve, for those insights. I think we can all agree whether or not we work in supply chain or healthcare, this topic is so timely and relevant as we watch the vaccine roll out across the globe. So we have a couple of questions coming in, and I'm going to start with a question for both of you. Why is the U.S. disproportionately affected by the pandemic compared to developed as well as developing healthcare markets?
Take a first stab on that. I mean, we have very open borders. We also test quite a bit. And when we tested, we never made a distinguishing capabilities on whether or not you have COVID, how many times you're repeatedly tested for COVID, and are you being tested for COVID versus having antibodies for COVID. So I'm not saying entirely that we have a metrics problem, because the hospitalization data shows that we have definitely other concern. But the reality is, culturally, the U.S. is different, and we basically value freedom. We try to move mobility. If you actually compare us to other G20 countries, we're bad, but it's a neck and neck race for us in the UK in terms of where things have been and how we've done things differently. There aren't really great answers for it other than to say that we are, without actually putting everybody into a really harsh quarantine and without really changing our data metrics to show a denominator that actually provides to see what does differently, it's hard to say, A, whether or not we truly are the worst, number one, and then B, whether or not the American population would ever have been willing to essentially take a true government lockdown.
KK, do you have any thoughts on that?
Sure. So I'll again wear my supply chain lens and hat. And the best way to put it is that we chose to ignore the demand signals. And the demand signals here can be broadly categorized. Anytime we think of demands, there are sort of three aspects to a demand. One is the volume, the other is the variety, and the third is the location. When you think of demand uncertainty, these are three facets of demand. We never quite expected the volumes that we would, and we chose, even though we were seeing where stuff was happening in Italy, the rate at which things were progressing. And I'm saying Italy because it's a comparable country, as opposed to, say, China. Then we also realized very quickly early on that there was variety. I mean, some population, be it age or ethnic groups, were being affected, and the conditions of living matter. I mean, some people cannot socially distance because they live, in close proximity, and that is how the culture and society works. Yet we chose to do not much, and some of it is right in the hotspot, right where our school is located. And then there's the location, and that the location issues were simply being, almost, that is probably where we came hardest when we decided to have policies to travel or not to travel, let people or not to let people in. Yet I think, within the country, travel was not managed well at all. I mean, as a matter of fact. And so there are when you come to think about the demand signals, we chose to ignore it. And more importantly, we had what we call a phenomenon of underreaction. We thought nothing is going to happen, nothing is going to happen. We kept going to even schools, and yet we kept asking our colleagues in China, from China, what's going on there? And last but not the least, I think what Steve said, and I would agree on this, is that I think we need to be thoughtful about the ups, in the pros and cons of a managed care system that limits our ability to provide care, the kind that I'm espousing, yet there's a cause for a pause. So this is where I'm going to stop, but I'm happy to talk more.
Thank you both. We have a number of questions coming in about the vaccine. So I'll ask this next question for both of you. KK, you talked a little bit about the push and pull of vaccine distribution, but can both of you talk a little bit about best practices that we're learning from other states, West Virginia, for example, and how Minnesota should move forward towards implementing and improving our vaccination rates and distribution process?
I'll take a quick stab. What West Virginia did that was different was that first of all, they recognized that the vaccine was coming early. I think that was one thing that was unfortunate, that some states weren't quite prepared to think that it really would come at bulk the way it did. And so they recognized it, and then they also organized differently on the ground with pharmacies that were local and not necessarily national chains, and pushed things out fairly aggressively in a fairly coordinated fashion, which is unusual because it's not what you would expect West Virginia perhaps to do. And then Connecticut did the same thing, working with their hospital systems. And so they basically was really, I would say they actually applied KK's principles in terms of leadership, is what the states that were successful did. I think other states relied too much on expecting that there would be a real game plan out there without second guessing and thinking themselves like, we're in a war economy, we need to figure out how to move things on. The easiest way for states to have basically been super aggressive about it, if they want to do KK's push approach, was essentially to activate their National Guards. Because the distribution of the vaccines was a given that would go to states and major city municipalities. People forget, but there was New York State and New York City were both getting them. And there was just basically a political war between the two to figure out who's going to do what, which was just ridiculously dumb. Both of them could have activated their National Guards, as they're doing now, to move forward. It didn't take the technologies and the thoughts of how to do this was shown in every major motion picture talking about this stuff for years and a day. all you had to do was just sit down and figure it out. And unfortunately, it took several states a month or two, including Minnesota, to figure that out.
So, Sarah, this is a great question. So thank you for bringing this up, because this is close to home, and that's what we all care for, and we want to sort of put our heads together to figure things out. Let me give you a little bit of a backdrop, because I'm quite involved in looking at some of the rural Minnesota COVID care supply chain issues. And I can tell you, talking to some of the leaders of our healthcare systems, and they're really pulling up their hair because there is a lot of flip-flop that has happened already with the Walz administration. I mean, and including things like, we'll have a lottery and then we choose one way and then we move back to another way. And so I'm not going to get into the details. That's not terribly relevant. What is relevant is that given where we are, this is a very solvable supply chain problem. So if you could just turn it over the data to us, and if you can engage us, I think we could potentially start coming up with a plan to execute, and we learn as we go along. So I don't think I want to make it evidence-based. So my call, and what I would, and to the folks, including our leaders, would be give us a seat on the table. We won't make things worse. We'll probably make it better, but give us a chance. And we are already doing a lot of this stuff. And supply chain is a discipline. It is a profession, just like public health, epidemiology, call it infectious disease, call it, policy, healthcare management. It is a formal discipline, and we do that work, and we care about issues of healthcare disparities, which is, as you can see, is one of the larger issues that is really tearing us apart. And we need to address this, which basically means we need to be mindful of the different types of demand imposition on us, and then how do we fulfill the demand, which is different strokes for different blokes. And we can do this in a fairly responsible way. And we can also think about what to order, how much to order, all that stuff. And there are details because, it's a cold chain. So you need, refrigerator trucks or refrigerations in that sense. And those are things, and that you need to be, vaccinated twice. So it's a more complex issues, but solutions do exist. If only we have the data, we can get to work.
Thank you both. I think we can all agree it seems like a very complex issue. We have a lot of questions coming in. Another question, maybe for both of you actually, is how does US citizens' willingness to receive vaccinations influence the distribution strategy?
The anti-vax issue is a major concern. Basically, when everyone's turn comes up, if you're registering, you should go. If you don't do that, I think it's good citizenship points. No one is immune from essentially this thing affecting them. People have different levels of immunity based upon what their exposure might have been already from asymptomatic people. But if we're really expecting to get to some level of herd immunity, I think the vaccinations pieces are going to be important. Now, I tend to think that we actually might be much closer than where we are, but what I'm concerned about are the variants of COVID and the mutations that are occurring. And the only way to get a hold of those mutations, because they've racked Europe basically over the last 2-3 weeks, not nearly as much in the US. We're worried about it, but the only way to get around that is essentially rapid vaccinations we've seen so far, these early evidence in the UK and in South Africa that the variants are actually somewhat under control from the vaccines that are out there.
So Sarah, from my standpoint, the way to think about this is that when you think in terms of demand for healthcare, it is driven by affordability, access, and awareness. Thank God affordability is no longer a major concern right now for vaccines, but awareness is everything that we're talking about, and vaccines in general. There has been an awareness issue. So when people have been vaccinating, think of Pakistan and people going out, and these have been in media news. Vaccinators have been even killed because people have had that kind of antagonistic point of view. So the issue that is to make people aware more than ever before of this vaccination, and that's what public health campaigns do, is to inform. And like everything else, there will be those who are believers, there'll be those who are naysayers, and then there are those who are hedgers. So when we provide evidence, more likely we are now going to transition hedgers to be believers, naysayers to be hedgers. And as long as we can get onto that trajectory, I think we will be heading in the right direction. How fast it can happen will depend upon the time, effort, and the kind of evidence-based approach that I'm suggesting we take. Let's get the data. We will learn a lot, but let's get going. I mean, there's nothing here to wait, because that awareness issue is a very serious issue. It's a structural demand estimation problem, because effectively, think of mental health care. People who have it deny it. People have stigma. And so a lot of times your demand estimates are always depressed. You have to get around, and how we, even in our university, how we come around. That's an example that when you create awareness, people are willing to seek help. And when they seek help, you provide help and you figure out ways to do things. I would take that approach. We have done it in the mental health care space. We have done it in the underdeveloped countries along the same thing with kids born in congenital heart disease in Gansu province in China. Basically didn't think parents never thought that the kids could be saved. But while the care was being offered to them by the platter, by like Children's Heartland, and that did come around. So I think we have concrete evidence that public health campaign and awareness, creating awareness, does matter and does translate into identifying the real demand, and then we'll figure out how to fulfill the demand. So those are my two responses.
Yeah, thank you. Okay, a final question. I'm going to ask you to predict the future. What is the best guess for when the vaccine will be available and when things will get back to normal?
I'll take a stab. I would say that assuming that the Johnson & Johnson vaccine basically gets approved for use, emergency use in the next, sometime in March or April, I would say that probably by the time we get to probably end of May, April, beginning of May is when that can really move. There's a lot of doses that are available for it. The key is it doesn't need refrigeration. You can go to Walgreens, you can go to a local pharmacy. So that everyone, myself included, has been waiting for that to occur, where the easiest way to get stuff out through the pharmacy chains can move easily. But the complication to date has been, to KK's point, is that particularly the Pfizer, Moderna, it has to be super refrigerated, though there's recent studies saying it doesn't have to be quite as refrigerated as before. But because of that, if I actually had access to the database of all the distribution pieces when I was in the administration, everybody who was receiving it was a healthcare facility. It wasn't like it was going to like a public health administrator or a county health department. Every single one of them was going to a hospital system there. The concern was that the hospital systems, when they got it, weren't geared up for prevention. There needed to be a lot more KK's trainees out there to work with all those hospitals to make that actually occur on a widespread basis. But I do think that we should be able to see, hopefully by this summer, everybody who wants to get access to a vaccine should be able to get it.
So Sarah, the way I would answer it, that I just don't like, we are in the business of forecasting, so I don't like to sort of throw guesses out there. I'd like to, provide some context to how I would approach it. And it is either or. So are you bringing a supply chain guy on the table? If the answer is yes, I think you will help yourself. I don't know how much you will gain, but you'll certainly gain a whole lot. The other piece is when you think in terms of vaccinators, which is, I think, President Biden's one of the key points. It's not just the National Guard. I mean, if you think about who are the vaccinators in World Health Organization, UNICEF, we have tons of students in medical schools, nurses. What could be a better way to baptism by fire, to get them out there, give them the capability and support them? So the vaccinators piece can be mobilized in ways that I think we have not been thinking. And we have to create conditions that whereby people are willing to accept the visit. Just like, who knows most about door-to-door? Is our US postal worker, the guy who shows up every day, does the rounds, visits every house. I would piggyback on those guys. I would tap on them. Then you have the Schwann's trucks and the refrigerator trucks, the Cobons floating around. So there are people who are moving the cold chain, the C.H. Robinson Fresh. We need them. And finally, what we need is the Ubers and the Amazon's wisdom. Once we have figured that piece out, how to get toward, just like we are getting so much, dropped off on our doorstep. So people know how to get to you at your doorstep, regardless of whether you have a family home or you are living in a high-rise or apartment complex. I would take that approach. I would not try to guess estimate what the timeline is, but to me, what's most important is we maximize coverage and we leave no one behind. And we can do it routine, regular, and repeatedly, and we never get our guards down in the days ahead. That's the way I would approach it.
Yeah. All right. Stephen, KK, thank you so much for your insights today. And thank you to everyone who was in the audience today. Our next event will be March 19th, featuring Carlson School faculty member Ravi Bapna and Dr. Samir Badlani, who is the CIO of M Health Fairview for digital transformation. They'll be discussing how to harness the 4 major trends driving digital revolution in firms. We welcome your feedback. There is a link to a very brief evaluation in the chat. We'll also be sending a follow-up email to get your feedback as well. Thank you all very much and have a wonderful day.